As we just discussed together, I'd like to highlight this topic, which is luteal phase support. So it is a new discussion of an old topic, because all of us, when we were students in the Faculty of Medicine, we know that luteal phase defect is a common topic in all schools of medicine. But why we discuss it now in 2025, which is strange to discuss an old topic? Because it is a dynamic topic. It has been changed and the medications are changing. So I'd like to highlight the main items of this discussion, including introduction, definition, etiology, diagnostic and clinical presentations, causes or types, and I put line. This is the regarding luteal phase defect, and then we will discuss luteal phase support, which is the main target of this topic. We know that luteal phase is the phase of progesterone, which comes from the theca cells under the stimulation effect of luteinizing hormone, LH. And the corpus luteum secretes progesterone to change the endometrium from non-responsive or non-receptive into receptive endometrium to be ready for implantation. But if no fertilization occurs, the corpus luteum will shrink, and this will lead to luteolysis, and the corpus luteum will die, okay? In such a case, decrease of progesterone. But if pregnancy occurs, the syncytial trophoblast of the embryo will supply the corpus luteum by HCG, which is surrogate to LH, to continue to secrete progesterone. And this starts at 5 weeks after pregnancy and is completed at 12 to 14 weeks. Now, this topic is controversial and confusing for most of the doctors, because number one, the name of this disease. Is it luteal phase defect? Is it luteal phase dysfunction? Is it luteal phase deficiency or luteal insufficiency? All these terms are used in literature. And what about the definition of luteal phase defect? It has a clinical definition, which is the luteal phase is 10 days or less, or biochemical definition when the mid-luteal serum progesterone is 5 nanograms per milli or less, or combination. And previously, when we were students, they told us that there is histologic definition of luteal phase defect, that the histopathologist find retardation of the endometrium 2 days beyond the expected date, and this is nowadays not used. So the definition of luteal phase deficiency is 10 days or less. Usually it is between 12 and 14 days only. What about serum progesterone? In the early follicular phase, the progesterone level should be very low, 0.1 to 0.7. Pre-ovulatory increases up to 1.5. If it increases more than 1.75, this is an indication of cancellation of a cycle of fresh IVF, because high pre-ovulatory level will lead to poor pregnancy rate. But in the luteal phase, the level of progesterone rises and can reach up to 3 nanogram per milli, according to the American Society of Reproductive Medicine, can reach to 5 nanogram or more, can reach to 10 milligram or more. What is the level I have to select in my clinic? I don't know, because different societies recommend different levels. And this is a confusing point. Why it is confusing? Because mid-luteal progesterone is not a reliable method to estimate the luteal phase defect. Because in every day, which is day 21, for example, the patient will have between 8 and 10 different measurements. If you take sample morning, evening, afternoon, it will be different from each other because of fluctuation of the level of the pulsatile release of progesterone. There are peaks and troughs of the hormone, in addition to difference in the length of the menstrual cycle of ladies. And importantly to know that in normal, regularly menstruating ladies, some of them will have low serum progesterone despite regular menses, and the length is more than 10 days. and there are inter-cyclic variations and inter-individual variations. So the definition is confusing. The name is confusing. What about the etiology? Most of doctors, when they hear luteal phase effect, oh, we have to look to the luteal phase. No, this is not good. Luteal phase defect is the main cause due to decreased progesterone amount or duration or insensitive endometrium to the normal level of progesterone. But don't forget to look at the follicular phase as a cause of luteal phase defect. So this is the first mistake of general practice, that you don't look to the follicular phase. You have to ask this patient about ovulation. Is she ovulatory or not? Is she PCOS or not? If she has low estradiol or low FSH or altered LH-FSH ratio or not. If these factors are present, so you have to expect luteal phase defect in the late part of the menses. So don't forget to look to the follicular phase. And that's why some studies try to predict luteal phase defect by looking at follicular phase measurements, the estradiol. For example, this is a recent study, 2024, and another study tried to find out correlation with the luteal phase effect by measuring the baseline progesterone day 1 or day 2 or day 3, and this is published just before 1 week to have information about the pregnancy rate and success of treatment. All these are trials using the follicular phase to help you in the diagnosing luteal phase effect. But generally, the definition as recommended by the American Fertility Society, that we have to rely on clinical diagnosis. The luteal phase 10 days or less, this is luteal phase effect. Hormonal definition or biochemical definition is not as accurate as calculation of the luteal phase. Now, what's the clinical presentation? I already discussed with the doctors now before all of you come that what are the patients in your clinic with luteal phase defect. Unfortunately, most of the doctors look to luteal phase defect as infertility problem. When we don't have a patient coming to infertility, so she is not a patient for luteal phase defect. This is completely wrong. Most of the patients with luteal phase defect are non-infertile patients, are fertile patients. So number one, you have to put luteal phase defect in your mind in all cases in your clinic with gynecologic problems or polymenorrhea, gynecologic problem or premenstrual spotting or premenstrual bleeding. Those patients are a good bulk of your patients in the clinic that have luteal phase defect, and don't ignore them, don't underestimate them. It's a real problem to have polymenorrhea. Every 15 days she has menses and stays for 7 days or bleeding for 7 days before menses. This is a great problem, social problem, psychological problem, religious problem. She cannot go for praying, cannot go for Umrah, and this can lead to iron deficiency anemia and general malaise. So why to ignore this problem in your patients? Don't think of infertility alone. You have to think of the gynecologic problem. Regarding infertility, luteal phase defect can lead to unexplained infertility in up to 10% of your cases, and this is a recent study. Also recurrent implantation failure, recurrent pregnancy loss, IVF and IUI problems. Also sometimes the luteal phase defect can be associated with hyperprolactinemia, hypothyroidism, and others. So the main causes of luteal phase defect either idiopathic. This is a common question by the patients. If you tell the patient that your day 21 progesterone is low or your luteal phase is less than 10 days, she will ask you, what is the cause? Doctor, tell me what is the cause. The cause may be follicular phase, as I already mentioned, poor ovulation, PCOS, stress, increased age of the patient, anxiety, uterine anomalies, or hyperprolactinemia or thyroid dysfunction, in addition to IVF patients. So if we discuss in short the hyperprolactinemia and hypothyroidism, they will lead to altered GnRH secretion, and this is one of the causes of luteal phase defect. What about IVF XZ? And I deleted many studies regarding IVF, but we know that the steps of IVF XZ are pituitary downregulation or pituitary suppression. This is number one. Number two, controlled ovarian stimulation. Number three, triggering, which is final oocyte maturation. And number four is the ovum pick up. Okay? So in every step of the 4 steps of the IVF, the patient is liable to have luteal phase defect. Okay? Why? Because downregulation, you decrease the number of receptors by long agonist protocol, and this will decrease receptors of gonadotrophins, and this will lead to loss of pulsatile LH. But in pituitary suppression by the antagonist protocol with preserved number of receptors, the patient again will have loss of LH pulsatile, which is transient and persistent and immediate effect of antagonist. So also in the IVF patients, you give them gonadotrophins to have more follicles, and this will increase the level of estrogen and progesterone, and this by feedback, negative feedback, will decrease LH, and this is the cause of luteal phase defect. What about triggering? We give trigger for the patients of IVF and non-IVF. This may be HCG. We know that in IVF we give around 10,000 units, or urinary HCG, or recombinant HCG, which is 0.25 milligram or 250 microgram. And this HCG is one of the causes of luteal phase defect. When you give your patient an HCG injection for triggering ovulation, you are inducing luteal phase defect. You are causing luteal phase defect. That's why we don't have to overuse drugs, to over-prescribe drugs to all ladies giving them HCG, because the HCG will lead to inhibition of endogenous LH, and there is what's called luteal gap, which is distance in time between the exogenous HCG and the endogenous HCG from the fertilized embryo. Also, if you give GnRH agonist as a trigger, particularly in antagonist protocol or high responders or PCOS and so on, in this group, this is short acting, but it will lead to immediate or rapid luteolysis. So the first is HCG is causing luteotrophic effect, increased duration of secretion, and this is good, increased duration of LH secretion, but it has deleterious effect, which is ovarian hyperstimulation, because it will lead to increased vasoactive substances like vascular endothelial growth factor, which lead to fluid shift from the intravascular volume to interstitial volume, leading to ascites, pleural effusion, hypotension, thromboembolism, and organ failure. But GnRH agonist is better regarding the ovarian hyperstimulation, but it leads to luteolysis. Some doctors may prescribe recombinant LH, which is under trials, or kisspeptin, which is a new and again under trials. So HCG is a cause of luteal phase defect because of inhibition of endogenous LH and luteal gap between the exogenous and endogenous HCG. Regarding the GnRH agonist is good regarding minimizing the risk of ovarian hyperstimulation, but it will lead to luteolysis and luteal phase defect. Well, what about the ovum pickup? When you go to the operating room to make pickup of the oocytes of the follicles, you are taking the fluid and aiming at to take the follicle, the oocyte. And the introduction of the needle inside the oocyte will lead to destruction of cumulus or forum, which is some condensation of the granulosa cell secreting progesterone, which is surrounding the oocyte. And this invasive procedure is one of the causes of luteal phase defect. And okay, so these are some information about the luteal phase defect. We understood that it is a misdiagnosed problem because doctors are focusing on infertility and leaving gynecologic cases, and every step of the IVF can lead to luteal phase defect. So we have to give some patients luteal phase support. Those patients, we can classify them into gynecologic and infertility. In this algorithm, I tried to summarize to you the idea of the published data on the luteal phase support. We have in the clinic of most of us gynecologic cases. Don't ignore gynecologic cases with polymenorrhea, with premenstrual bleeding, with premenstrual spotting. Those patients with clinical and or biochemical diagnosis of luteal phase defect should be treated. Don't ignore them. And treatment by progesterone. Any progesterone you can give to those patients to control bleeding and to prolong the luteal phase. Any progesterone, okay? Including the natural progesterone, including dydrogesterone. But you can give any type of progesterone, okay? This is a category, and this is the main category in your clinic. The second category is infertility patients. Those are infertility patients. We have to ask ourselves, the infertile patient has a clinical or biochemical or biochemical evidence of luteal phase defect, I have to give them progesterone or whatever luteal phase support. But if they are without evidence of luteal phase deficiency or defect, I don't have to give them progesterone as an overuse of progesterone or luteal phase support, but I have to select the patients who are using gonadotrophins or IVF or frozen embryo transfer. So the gynecologic patients with clinical evidence or biochemical evidence of luteal phase defect, gives them luteal phase support, any progesterone. Infertility with clinical evidence of luteal phase defect, gives them luteal phase support. But you have to, an infertile group, the whole infertile group, you have to avoid 19 nortestosterone derivatives like norethindrone acetate or medroxyprogesterone acetate. Don't give these drugs to an infertile patient willing to have a baby. Don't give them this type of progesterone because it has an androgenic or corticosteroid effect on the embryo, and this may lead to some congenital anomalies of the embryo if it will occur. So in those cases, give them natural progesterone or dydrogesterone, as I will discuss. And the patients with drugs, induction of ovulation, those patients are receiving clomiphene citrate or tamoxifen citrate or letrozole. They don't need luteal phase support. They don't need luteal phase support. You give luteal phase support as a routine or prophylactic for patients who are receiving gonadotrophins only. But those who don't have evidence, clinical evidence or biochemical evidence of luteal phase deficiency. So the non-IVF infertility patients, like normal patients, timed intercourse, without gonadotrophins, don't give them. Okay, II with gonadotrophins, you can give them luteal phase support. But without gonadotrophins, don't give them, sorry. Okay, so what about IVF? We have to give, because I told you 4 steps of IVF can lead to luteal phase deficiency. So the natural cycle IVF, there is what's called natural cycle IVF, which means IVF without induction, without drugs. You can ignore giving progesterone, provided the patient is young age and regularly menstruating and without evidence of luteal phase insufficiency and normal body mass index as found in recent publications. But against this suggestion, I say, what about ovum pickup? You are doing natural cycle IVF, but you are perforating the uterus, the ovary, and making destruction of camulus or forum. You are inducing luteal phase defect. So this point is not clearly discussed in these publications. But there is a recent publication regarding luteal phase support only on those cycles when you give gonadotrophins. Again, if you give clomiphene citrate, tamoxifen citrate, letrozole, don't give luteal phase support as a routine prophylactic. But if the patient has clinical evidence of luteal phase deficiency or laboratory or biochemical evidence of luteal phase deficiency, you can give them support, okay? We don't have to be confused. If the patient has clinical manifestations, biochemical manifestations of luteal phase defect, give them. If don't have, we don't have to give them prophylactic. As mentioned also in many publications that don't have to waste time in fertility sterility. Regarding frozen embryo transfer, we can give progesterone or luteal phase support in HRT cycles and modified natural cycle. But natural cycle, we don't have to give luteal phase support. So this is the distribution of which patient should I give luteal phase support. Not all cases in my clinic, I have to give them luteal phase support. If she is gynecologic with gynecologic problems, okay, give them. If she is infertile with gonadotrophins or IVF or frozen embryo transfer, give them, okay? What about timing? Which time should I give the patient progesterone for luteal phase support? Last week, I saw many doctors wrote to the patients dydrogesterone, and one of them mentioned it starts from day 13 of the menses. Why? Who told him that day 13 is the time of progesterone? This is not good. This will lead to premature progesterone rise, which decreases pregnancy rate. Don't give progesterone before ovulation at all. This will lead to decreased pregnancy rate. Progesterone is given after ovulation and natural cycle. So you give her trigger, for example, after that 1 day or 2 days, you start progesterone. You give trigger day 13, you start day 15 or 16. Don't give progesterone day 12. Another case, the doctor, she told her, she was before 2 days. The doctor told her, take progesterone, dydrogesterone from day 10 of the menses. This is catastrophe. She needs to the patient to get pregnant. Day 10 progesterone, increasing progesterone level will lead to decreased pregnancy rate. So please, if you give progesterone, give it after triggering, after ovulation, to avoid premature progesterone rise, which is deleterious to pregnancy. So timing should be at least 1 day to 3 days after ovum pickup in IVF cases. If I give trigger for a patient, I have to wait 1 day or 2 days. Don't give with the time of triggering. This is important. Okay? Which type of medication should I give for luteal phase support? And this is the title of the topic. Sorry for the long introduction. But which type of luteal phase support I give to the patients? We have 4 types of support as mentioned in textbooks. Regarding the support, we have progesterone, we have HCG, we have GnRH agonist, and we can give recombinant LH or estrogen. Regarding recombinant LH, it's new under trials and not recommended by the ISHRI. Regarding estrogen, there is no sufficient data to support its role. I know that IVF doctors always give estrogen for the luteal phase to help support, because estrogen is responsible for priming the receptors for progesterone. But this is without evidence, sufficient evidence as mentioned, and is not recommended by the ISHRI as well. So we can give the patient for luteal phase support progesterone, which is the main luteal phase support, or HCG or GnRH agonist. Now, progesterone, I told you for infertile patients, you have to avoid 19 nor testosterone derivatives, and you have to give natural progesterone or synthetic progesterone, which is dydrogesterone. And this in cases of IOI, IVF, frozen embryo transfer, gonadotrophin, recurrent implantation failure, pregnancy, recurrent pregnancy loss, and so on. In this slide, I tried to summarize to you the idea behind giving natural progesterone or synthetic progesterone, which is dydrogesterone. Not all synthetic progesterone are allowed for infertile patients. We can use only synthetic progesterone, which is dydrogesterone, which is a stereoisomer of progesterone. In this slide, if you understand it, you will understand the difference between different types of progesterone. I summarized a lot of words written in textbooks, particular pharmacology, about these 2 drugs. Natural progesterone is well known, okay? But synthetic progesterone, which is dydrogesterone, is different because the natural progesterone, the molecule like this one. But for dydrogesterone, it is bended like this. It's bended like this. So this is the natural progesterone and this is dydrogesterone. Why it is bended? Because there is an important bond between C6 and C7. And this is the cause of this bend. And this is a very important modification from natural progesterone because it is responsible for the high selectivity of the dydrogesterone to progesterone receptors. It is a good selective agonist to progesterone receptor because of this bend of the molecule. Also, there are some different orientation of alpha and beta, but it's not important as this bend between C6 and C7. And by this way, the dydrogesterone is a highly specific, highly selective for progesterone receptors. By this way, since it is highly selective, we need small dose because it's highly selective. I cannot, if the drug is not selective, we have to give high dose to reach to the receptors. But it is very selective due to this bend, so we need small dose of this dydrogesterone. This is the number one. Number two, it has high bioavailability, also due to the change in the configuration of this molecule. So high bioavailability reaching up to 28%, while the natural progesterone just 5% of bioavailability. So you cannot give natural progesterone capsules 10 milligram or 20 milligram. You cannot give because this 5% bioavailability. If you give 10 milligram, the bioavailability 5% of this 10, the endometrium will, the body or the serum will have 0.5 milligram, so the endometrium will have very, very trivial amount. So the high bioavailability allows you to give small dose with high efficacy as high dose of progesterone. Another important issue to differentiate between the natural progesterone and dydrogesterone is the avoidance of the agonist effect on androgenic, estrogenic, and corticosteroid receptors. So it doesn't have side effects regarding androgenic effect, regarding estrogenic effect, or corticosteroid effect. This is another important issue. So if you look to the this slide, you will find the dose regarding the dydrogesterone is 20 times less than the progesterone, natural progesterone, regarding it whether vaginal cream or vaginal gel or pessaries or whatever. So this is the important difference between them. The bend, don't forget, the bend is very important for the high selectivity. Last and not least important, which is a future point in research, is the dydrogesterone has systemic immunomodulation. So it is good for patients with recurrent implantation failure or recurrent pregnancy loss, unlike natural progesterone, which is just small dose reaches the endometrium because of low bioavailability. And this is another advantage of the dydrogesterone. In this table, I summarize to you the differences between the different types of progesterone, natural progesterone and synthetic progesterone. The natural progesterone usually we use in practice, particularly IVF patients, we use vaginal approach, which are vaginal pessaries, micronized vaginal pessaries, or micronized vaginal suppositories, or vaginal cream. Or injections, intramuscular injection or subcutaneous injection, these are available. Regarding oral micronized progesterone, it is not recommended because very low bioavailability and first liver pass, but the vaginal first uterus pass, it goes from the vagina to the endometrium directly and myometrium. So it is advantageous over oral method. But the vaginal approach may lead to irritation, vaginitis, infection, interfere with the coitus, and so on. And many patients do not like to put vaginal pessaries, particularly if they are new pregnancy, for fear of abortion or whatever. So many patients do not like. That's why some companies recommend rectal use of the vaginal capsules. But again, the absorption or bioavailability of these capsules, even rectally, is 5%, which is too low. If you look to the first row, you will find the doses here for dydrogesterone is 20 to 30 milligram as recommended in most of the publications. Some of them use 40 milligrams. But if you look to the oral micronized progesterone, you will find 600 milligram. So from 20 milligram to 600 milligram, these are the differences because of the bend of the molecule. As I told you, regarding vaginal micronized suppositories, starch suppositories, 400 milligram once or twice daily. So you can give the patient 800 milligram, and there 20 to 30 milligram. If you give the gel, you will give 90 milligram once daily or twice daily. What about injections? I'll avoid the vaginal approach, I'll avoid oral approach, I'll give injection. Okay, the injection will rise the level of progesterone as if it is normal in the normal situation. It's a good achievement. But injection is giving the patient injection intramuscular can lead to inflammation, can lead to abscess formation, and sometimes can lead to some type of pneumonia. Dr. Muhammad pneumonia, xenophilic pneumonia, Dr. Wafaa. This is pulmonology concept. And these are even really pulmonological complications, and it's inconvenient to have injection intramuscular every day and leave your work to go to have injections and so on. So that's why they developed subcutaneous injection to be given by the patient, and this subcutaneous is given to her as 25 to 50 milligram daily. You can give 1 ampoule or 2 ampoules. The package comes with 7 self-administered injection. You can give the patient once daily or twice daily, but still it is expensive and it's not too much available in the market. Here also is not available. So now we are confronted with the difference between the different methods, but which method is best? Till now we cannot say what is the best, but I distributed to the whole methods of progesterone supplementation for treating, support for treating luteal phase defect. And the recent recommendation of the ISHRI 2020 mentions that you can give the patient natural progesterone or dydrogesterone. And dydrogesterone is advantageous, as I told you, to systemic immunomodulator, not only local, it works systemic immunomodulator, and it supports, it is selective progesterone receptor and good for endometrial receptivity and decidualization. What about IVF patients? The studies on IVF are too much regarding dydrogesterone, and recently there are 2 studies, Lotus 1 and Lotus 2, by the same group, and they compared 30 milligram dydrogesterone versus micronized vaginal pessaries, micronized vaginal gel, and they found comparable results, similar tolerability and safety profile. But this is oral, and this is gel or vaginal oral superior, and similar pregnancy rate and take home baby rate. And the same group published recently in 2020 a study to compare it to oral micronized capsule. Of course, oral capsule, as I told you, of low bioavailability, and they achieved higher pregnancy rate with the dydrogesterone versus the vaginal capsule. When they put it in the vagina, the high pregnancy rate was achieved with dydrogesterone. What about safety? Many concern regarding safety of dydrogesterone in pregnancy. All the studies mention that it leads to congenital heart disease or hypospadias. But if we analyze these data and teratogenicity, we'll find multifactorial causes of these anomalies. And in a recent meta-analysis and systematic review on 47 studies, they found the title is No Additional Risk of Congenital Anomalies After First Trimester Dydrogesterone, and this is a good meta-analysis actually. Okay, I don't need to give the patient progesterone, or she does like progesterone. She asked me, can I use the HCG which you gave me as a trigger? Can I use it for luteal phase support? You say, okay, you can use it, but you are responsible for ovarian hyperstimulation if it occurs. It can lead to ovarian hyperstimulation because of prolonged eutrophic effect up to 6 days, and this is a risk of giving HCG for luteal phase support. Some studies use low dose, 1,500 units for this purpose, but it's better to avoid it. Can I give the patient GnRH agonist, which I use for triggering? Yes, you can. But usually the studies using GnRH agonist is in combination with progesterone, particularly vaginal progesterone, because it has short half-life and it supports the progesterone. As I told you, many regimens are published. We can give combination, not only progesterone alone. You can, I already mentioned, with GnRH agonists or other drugs. Some doctors, in particular in IVF, you see the IVF prescription around 10 drugs. I don't know from where they bring these 10 drugs. Some of them give intralabel before the IVF and during or after. Some of them give low-dose aspirin. Some of them give heparin. Some of them give whatever they need. Any drug can be given to this patient, and the patient is willing to have a baby. But all these add-on medications are not evidence-based, particularly estrogen, which is commonly used, as many studies found that it is not valuable. And this is a table of the add-on drugs used to enhance pregnancy, add on to the progesterone or HCG or GnRH agonist. And these are used in specific. Don't give the patient empiric medications. If you have a patient, for example, for PCOS, you can add metformin for her. You can add myoinositol for this patient. If you have a patient with thin endometrium, you can give what increases nitric oxide, which is L-arginine. You can give heparin for patients with thrombotic disease or history of thrombotic disease. You have to modify these add-on medicines, not to give them to all patients. And these drugs, by the way, are not available. For example, intralipid. Many patients calling me in the clinic, do I have intralipid? I need 5 doses, I need 3 doses. Doctors told me I have to take it. And she has to come and pay. The one session for intralipid costs $2,000 or something like this. It's very expensive without any scientific base. But a recent recommendation for American Society mentions that you can add cabergoline as an add-on line of therapy if the patient is at risk of very heavy stimulation, and you can start it from the day of ovum pickup. So in conclusion, sorry for the wide discussion, but in conclusion, we have to know that luteal phase deficiency is a significant health problem. It's not only an infertility problem, it is a health problem for gynecologic patients. And actually it is underestimated by this doctor on the left side. He looks to it as this small green part, and he does not look to the majority of the problem under the ground, or overestimated by some doctors who are over-giving progesterone or luteal phase support, and the problem is mild. So it is either overestimated or underestimated, and luteal phase support is mandatory whenever clinical and or biochemical evidence of luteal phase deficiency, and routine without clinical or biochemical, routine luteal phase support in infertility is indicated only in patients who are receiving gonadotrophins or IVF or cryo, frozen embryo transfer, non-natural cycle, okay? And progesterone, of course, is the best luteal phase support. We have to avoid HCG, as I told you, due to ovarian hyperstimulation, and gonadotrophin-releasing hormone studies are just in combination with progesterone. And decision of which progesterone route and dose it's a dynamic problem, still needs more research and more publications, more meta-analysis, more systematic reviews according to the patient's preference, efficacy, and potential side effects. And to summarize, this publication mentions that HCG is associated with ovarian hyperstimulation, vaginal, subcutaneous, intramuscular are similar. Intramuscular is not the first choice. Natural micronized progesterone is not effective, as I told you. And dydrogesterone, after its approval in IVF patients, is a promising, good for luteal, a promising option, as mentioned by the ISHRI, and actually seems to be a safe and effective choice to support luteal phase in IVF. And this publication, 2023, mentions that oral dydrogesterone may potentially become a preferred drug for luteal phase support in millions of women undergoing IVF because it is oral taken, small dose, less side effects, And future studies should focus on the evaluating the immunomodulatory property and the therapy, its role in recurrent implantation failure. So in conclusion, regarding the oral medications, I prefer the oral medication actually, because many patients suffer from vaginal approach and intramuscular approach, and the oral dydrogesterone is advantageous because it's oral, high bioavailability, small dose, less side effects, selective progesterone receptor agonist, nearly no androgenic, estrogenic, or corticosteroid agonist activity, has systemic immunomodulatory effect, approved for IVF and ICSI and early pregnancy, comparable results to vaginal, micronized vaginal pessaries and gel, superior to micronized vaginal capsules as mentioned in the publications. Thank you. Sorry.